Hi, everyone. Thank you for joining us today. My name is Adele White. I'm a project manager here at HCET, Healthcare Education and Training, and you are in the right place if you are looking for a webinar hosted by HCET with Dr. Emily Zars today on addiction and trauma. So let me briefly introduce you to Healthcare Education and Training, HCET for short. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And we're an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental human right. Next slide, please, Dr. Zars. So right here, you can see um, how you are all able to enable closed captions. Down at the bottom, you can see the little CC that's circled. You can enable live transcript, and then that will allow you to show subtitles. Next slide, please. So throughout the presentation today, we want to encourage you all to submit your questions via the Q&A box, and it's circled right there how you can submit it. You'll be allowed to submit questions throughout the presentation, and then we will hold them until the end, and we'll have some time to get everybody's questions answered. They can also be sent anonymously if you would rather not have your name attached to it. So just know that that is an option. And again, we will hold all questions till the end. All right, next slide. And we would love for you all to follow us on our social media channels. We have Facebook, Instagram, our website, hcet.org. So check us out. We have lots of trainings and recordings of our past webinars on there if you would like to learn more. Next, please. And this webinar will have an evaluation following it. We would love to hear your feedback. We always want to do better, learn, and grow from people who attend our webinars and see what we can do differently in the future. So there'll be a QR code at the end. I'll put a link in the chat, and there's a follow-up email sent after the webinar that will allow you to access this really short little post evaluation. If you're having any technical difficulties during the training, this email updates at hcet.org is how you get in touch with someone who can help you. And my colleague Jen is monitoring that email. So thank you, Jen, for that. And at our website, hcet.org, you can view all of our archived presentations and see a list of what we have coming up. Next, please. This presentation is eligible for nursing contact hours. So in order to receive nursing contact hours, you just follow the instructions right here on the screen. Pardon me. Attend the entire webinar, return a completed participant evaluation and post-test, and then complete the nursing contact hour form and email it to my colleague, Kelly, at kbradford@hct.org. And these instructions will be in the follow-up email. You don't need to write this down right now. Thank you. Next slide, please. So now I'm excited to finally introduce you to our presenter today, Dr. Zars. So Dr. Emily Zars is a board-certified psychiatrist with additional board certification in addiction psychiatry and addiction medicine. She completed medical school residency and addiction psychiatry fellowship at the Indiana University School of Medicine, so right here at home. She's the director for the Addiction Medicine Fellowship at the Community Health Network in Indianapolis and works in an outpatient setting. Dr. Zars is also the chair of the Commission on Physician Assistants at the Indiana State Medical Association, an assembly representative of the Area 4 for the American Psychiatric Association, and a psychiatric leader for Judges and Psychiatrists Leadership Initiative at the APA. She enjoys teaching about trauma and its role in addiction and recovery and expanding access to addiction services outside of behavioral health. She enjoys cooking, traveling, and hanging out with her husband and two young daughters. And so now I'm excited to finally turn it over to you, Dr. Zars, to discuss trauma and addiction.
Thank you so much, Adele. All right, I have no relevant financial interest or relationships to disclose. Here's our objectives for today. So the theme is going to be definitely the connection between trauma and substance use, but we'll go into a lot about vulnerabilities and risk factors between the two. We'll go a little bit into diagnosis and kind of ways to then apply this information to maybe change practice styles or assessments, and just kind of making sure that you have a trauma-informed system of care in your organization, from kind of front door all the way through the treatment process to really just make sure we're optimizing the best possible care for the people we serve. So typically, especially in the psychiatry world, we explore trauma, particularly related to the idea of post-traumatic stress disorder. There's not always a broad understanding of what trauma might mean outside of that label of PTSD. And it's kind of the longest consistent conceptualization of trauma, but there's a lot more trauma than just that. And so for PTSD diagnosis, you have to have a specific event that was life-threatening or thought to be life-threatening to yourself or someone else. That's a pretty strict requirement for this kind of diagnosis. And so today we're going to talk a little bit more about some other ways trauma is being conceptualized now that's a little bit more applicable to a broader audience of people suffering from these symptoms. So attachment trauma is what we'll talk about the most today, but this is the idea that if there isn't a safe space during a developmental period, it can impact somebody's ability to interact with others really throughout their entire life, but especially in that childhood development phase, which is really, really important to how our physical and mental health develop later on in life. So we're going to get in a lot about that relationship with a primary caregiver and then developing those regulation skills, hopefully, and if not, kind of what the consequence there could be. And then complex trauma, which we won't touch on too much today, but this is the idea that there's kind of repetitive or ongoing traumatic events. Usually it starts in childhood, but it may happen at any time. And then that repetitiveness of the trauma can more greatly impact someone, and the severity of the symptoms can be worse. Complex trauma is actually very, very common, especially in the patients that I see. And this may be a little bit kind of overlap with maybe a borderline personality disorder diagnosis in a lot of cases. That's kind of an easier way to kind of conceptualize what I'm trying to get at in terms of the impacts trauma might have. Obviously, people with complex trauma do not all have borderline personality disorder, and all people with borderline personality disorder do not necessarily have complex trauma, but there is a very big connection between the two. And so particularly emotion regulation and kind of sense of self, identity, ability to kind of tell what's real, what's not real, all of that can be greatly impacted when trauma has happened. And that's kind of the core of these relationship issues that could develop. We will do a very, very brief overview of neurobiology of trauma. We could talk about that for ages and ages. But really the things to keep in mind are these core ideas that a trauma is gonna kind of elicit that fight or flight or freeze response. And so this is the primitive originating part of our brain that's gonna respond in order to keep you alive. And so the goal is that if something traumatic or unexpected happens, your brain can prioritize a response that gets you to safety. So, even back in caveman times, if there's a saber-toothed tiger chasing you, you need to know, like, that's probably not good. I should probably not try to pet this thing. I need to run, right? And so that simple kind of response to something like that is how our brain first works. Pretty similarly in a way too, as a baby with no ability to express needs, your brain just has to kind of act in such a way in order to get those needs met. And so the hope is we develop that part of the brain into a much more sophisticated system, but it doesn't always happen that way if there are traumas or triggers or other things that get in the way. And so the goal would be that the limbic brain, the emotional side, during an episode of a traumatic experience, if that takes over, the decision-making, planning kind of part of your brain, that prefrontal cortex, can't be as active. You don't want the prefrontal cortex to be very active during a trauma because it takes too long. It's a slower response, and it's not really important to weigh what every single possible consequence of my actions could be if the most important piece is staying alive in that moment. So therefore, you're going to be less cognitively aware. You're not going to be able to take in as much input. You're really just going to be weighing the immediate risks and consequences and making a kind of snap emotional decision in a lot of ways. This can progress to the point where if there's enough trauma and enough response, you end up being kind of automatically irritable or reactive or blaming in situations that don't really warrant it, because your brain has kind of overdeveloped this automatic response in a way that's not very healthy or helpful. So the question becomes, why does it happen for some people and not everyone if they experience a traumatic event? And so vulnerable individuals are more likely to have repeated traumas. If they don't have that secure attachment during childhood, which we'll talk about here shortly, that's a big vulnerability risk factor, and therefore also emotional neglect, no consistency. So if they're raised in a space where they maybe travel between homes a lot, or one home is, many of those homes aren't super safe, or they kind of don't have any idea of what's to come, that can be difficult for a child during development. And then we do know that family history of trauma is a risk factor for kind of perpetuating that biologically as well as environmentally. And so people tend to raise their children the way they were raised, or they may revolt and try to raise their children completely differently than they were raised. But it doesn't mean any of that is good or better, or and no parent is perfect. And so it's really a matter of just trying to minimize the impact of past generations and their trauma on our future generations. And when trauma we know is going to stick around, unfortunately. So, and then it's important to know that not everybody who experiences a trauma, even the level of that life-threatening requirement for PTSD, is going to get PTSD. And so there's protective factors and ways that people can avoid developing these chronic long-term conditions related to trauma that we'll talk a little bit about today as well. So this is a somewhat newer concept related to trauma. There's a lot of different labels and names for this. I like this one in particular, chronic unpredictable toxic stress, partially because the acronym is CUTS. And so I think it kind of very adequately, or very accurately describes kind of what can happen if with these repeated events. This kind of concept was discussed in a book by Donna Jackson Nakazawa called Childhood Disrupted, and it's linked there at the bottom too, and then in the references at the end. But she talks about this idea that noradrenaline is the primary responsive neurotransmitter during trauma, and it actually specifically alters the way memories are formed when the noradrenaline spikes. And so if it's released and a memory forms, there's a relationship between the reality of the events, but more importantly, the emotions and kind of feelings related to that event. And so a memory is going to be formed in a certain way. This is important if you think about 4 or 5 people might witness the same thing. They may be siblings, they may be, in a very similar situation, but each of them is going to remember that event differently based on a lot of factors: their age, their previous experiences, their trust and relationship with whatever's happening, their own personal support or stress. So even if they have a lot of genetic consistency or a lot of environmental similarities, each person is individually going to respond to a situation and form their own memories. Over time, your memory is going to change and you're not necessarily going to actually remember what actually happened. And that's partly protective and partly just we can't remember everything. Some people have photographic memories and can remember everything supposedly, but most of us do not. And so over time, that memory is going to adjust and adapt. It's also going to adjust and adapt based on our own perceptions of relevant things. And so we become a different person as we age because we have new experiences and new memories. And so now a prior memory with a person or some sort of trigger may be morphed into something new because we know that person better and we trust them more now, or we know that person better and we trust them even less. And so that past memory becomes even more problematic and difficult to manage. And so I won't get into this relatively complex idea of implicit memory too much today, but it's really the idea that our perception of what happened is what's really impacting our continued interaction and our way of dealing with life. And that perception may not actually be real, but it is what our brain and our body are remembering. And that's where we have a chance to be able to make an impact through treatment. And then the amygdala is a part of the brain that's related to that emotion, kind of like we talked about earlier. So that emotional part of the brain is supposed to be more active more quickly so it can weigh those risks and benefits of decision making. And that automatic response is going to happen without control. And so this is a good thing in a lot of ways. If you touch the stove, you need to automatically realize it's hot and I shouldn't have done that. But it's also bad if your threshold for response is too quick. And so something that maybe isn't that stressful or isn't that harmful, it could trigger the same response as something that is much more risky or life-threatening because your brain has kind of misrepresented some of those risks due to your past experiences and how your brain becomes wired over time because of these memories. And so if you have those constant triggers or reasonably constant triggers or that unpredictability, it makes this overall concept that, okay, maybe I can't be safe and I have to be the one that's on edge, watching, waiting, always prepared for something that could happen. And then another theory that I think is really helpful to understand is attachment theory, which came from John Bowlby primarily. There's a lot of different psychologists and other people who've really expanded on this, but he really was the first to really talk about attachment theory and how this impacts human development. So children, especially in that first 2.5 years of life, they're going to just mimic and watch. They're just seeing what's happening around them. Their brain is going to be pre-programmed to attach to someone else, usually in human form as a caretaker, because they need to know what I'm supposed to do as all these things are happening. The child brain changes so quickly in those first 2.5 years of life that it's kind of pruning and adapting and choosing which pathways to prioritize based on those interactions. And up until well past 2.5, but definitely up until 2.5 years, you have to have someone else taking care of you and meeting your needs. They cannot feed themselves. They cannot change their own diapers. They cannot make sure they have warm, safe places to sleep. And so that requirement in human care that you have to have someone else to take care of you is biologically built into our form of development. The importance of this kind of moving forward beyond that is that if there's disconnect in that pattern in those first 2.5 years, and there isn't a person meeting those needs that's either consistent or so either the person is consistent or the needs being met is consistent, that's where we start to end up with issues with attachment. And so this second to last bullet point, the cognitive framework where somebody learns to understand the world is going to be based on that primary caregiver. This primary caregiver usually is going to be a parent or a primary relative or someone who's the person who's raising this child. Sometimes it could be somebody who's maybe a more like a daycare or kind of external person who just happens to be the most stable, consistent person in that kid's life. And then sometimes the primary caregiver comes in later in life and can undo some of the damage that was done earlier because it becomes a new, stable, securely attached person for that person to benefit from. But that first relationship with whoever that primary caregiver becomes does set the stage biologically for what's to happen next. This is obviously a period of time where this child has no control over who this person is going to be. Many times that's the most stressful time of raising a child. And so people's own influence in their own history, their own traumas are going to impact their ability to do this. And so there's just a lot of things that cannot be predicted or controlled at that time. So this concept from kind of his original ideas with attachment, I won't go into too much detail, but hopefully you can kind of reflect and look at this too. But the goal is secure attachment, this first one here at the top. And so this is the idea that you want the child to be able to trust and connect and kind of model healthy responses to new emotions, new behaviors, et cetera, and then also eventually be able to take care of themselves. And then the other three that a child may go into and out of still, so you can be securely attached and still have some of these other episodes of attachment. But if somebody is primarily only in one of these other attachment styles or pretty much never in a secure attachment style, that's where we end up with a lot of the issues we're going to talk about today. And so I think the anxious avoidant attachment, this third one, could be particularly relevant, especially into adulthood, because these children learn to just not talk about what they need. They don't express their needs and they just avoid. And then they also attempt to soothe their own needs. And if you are avoiding relying on others and self-soothing, this is where the pattern with the substance use or some sort of reliance on an external thing could happen because you're just seeking out something to allow for that self-soothing to occur. And then the disorganized attachment, I think this is a little relevant in terms of like behaviorally with children sometimes. So this is one that's common for all children to explore and kind of be in at times because they are still learning how to get their needs met or express their needs. And that can be a pretty normal, expected part of development as well. And then I didn't talk about anxious ambivalent, but I think that one's reasonably self-explanatory. But that's where those emotional outbursts, they overexpress their needs in the hope that maybe sometimes somebody will listen. And so as part of attachment, we also have to think about, okay, what happens if there is distress? And so these are three kind of concepts and stages of distress that he talks about. And so the hope is that if you're in this protest stage, and this comes from an experiment where a child was left in a room with their parent, and then the parent leaves, and they kind of monitored and watched what the child did if the parent had left. And then they extrapolated and kind of expanded it and kind of looked at other patterns further. But the origin of some of this research was based on this: just parents present, parents paying attention to me, parent leaves, and then parent returns, parent pays attention to me and is attentive, or parent returns and stays ambivalent and just kind of sits there and doesn't engage. And they kind of did a bunch of different ways of exploring what the child would do based on what their primary caregiver is doing. I say parent, but primary caregiver fits as well. So if a child is in a distress stage of protest, they're going to be very angry and kind of latch on and keep their child from leaving, or keep their caregiver from leaving. This is, most people who drop their kid at preschool or kindergarten, maybe, if that's kind of the primary time that this kid has been apart, this is the normal protest that's going to occur, right? But it's not normal if it lasts all day, every day for many weeks, because the child never adapted. And so sometimes the distress from being abandoned was what the child is perceiving. If that distress really impacts them consistently, even if their parent comes back and they're still consistently distressed, that can be very problematic. And then there's the despair phase, which comes next. The child will stop protesting, but they'll still be upset, and they will refuse other people, non-primary caregivers' abilities to try to comfort them. And then if this despair phase happens often, they will become withdrawn. And it can be really hard to kind of pull them emotionally back out of that space. And then opposite of attachment is detachment, which is not what we want. But if detachment occurs, then the child now doesn't care as much about their primary caregiver, because they've developed to the point where that separation has happened and they don't really, they weren't getting their needs met, and they aren't going to get their needs met. So they kind of have moved on. But the problem with this is they're still suppressing their emotions. They're still kind of isolating and withdrawn, but they're then going to kind of try to match some of that connection with other people. These people may seem happy with their caregiver, and they may seem, really fine, but they may also ignore their caregiver. Not really, none of this is very intentional. This is all just happening, but it's because they don't really care about that person anymore. There is no emotional connection or value to that relationship, because that detachment has continued. And so if a child doesn't respond to their primary caregiver leaving anymore after a period of time, or doesn't care that they're there and isn't running to hug them and be happy and really connected with them, that could be a very significant sign of major trauma that has occurred either recently or over time. So I alluded to this a little bit, but trauma can lead to substance use because people want to feel something other than what they feel. And so dulled cognition, this idea of not having to think, not having to have these racing thoughts, not having to process through and think about all these things, becomes a desire because they don't want to feel all the complex emotions that they've had to feel. Thinking clearly also means they may remember things more. And so people pull themselves out of this automatic fight or flight kind of response by being dulled through substance use. And then they may feel that feeling, even though it's not desirable and not great, is better than being more cognitively aware of what had happened before. And so withdrawal from a drug after you've used it allows for that clear thought to come back, and that drives people to then use again, because they don't want to be in that withdrawal and have to feel those things. And so going trauma triggers leading to substance use, and then also substance use triggers eventually could overlap, and so it all kind of blends into one. So when someone survives a trauma and they do fall into the pattern of substance use, it does often worsen the symptoms related to the trauma. It increases isolation, and then control over the substance use versus control over relationships or people all becomes very difficult. Substance use alone, regardless of trauma, is very victimizing. Trauma is very victimizing. And so now they kind of interplay with each other and make everything so much more difficult. And so any attempts that they were having to try to rebuild relationship or have connection are now worsened with the substance use, because people get frustrated and upset that someone continues to make that pattern of behavior and kind of continue to use. And so these are just some examples of ways that re-victimization could occur. So the question is, if using drugs is terrible and makes you feel worse, why am I doing it? Why do we keep doing it, right? Many people fall into kind of substance use dependence, kind of having a substance use disorder, because being sober and not on something and not clouded by a drug is very scary. They don't want to feel all those emotions and have all those memories. So they're afraid of living and feeling those things more so than they are about dying. Dying is a real risk, especially with like opioid use disorder, or even sedatives like alcohol, benzodiazepines, et cetera. There's a real significant risk of death, and that doesn't bother many people nearly as much as living in recovery and being sober. And so that it's different for everybody, and this pattern is different, and people have different risk factors, but trauma greatly increases the likelihood of substance use becoming a dependence and a really problematic pattern of use. And then, it's again, just like PTSD, if people can experience a trauma, they don't all end up with PTSD. People can use substances, they don't all end up with a substance use disorder. And that difference, a lot of it has to do with vulnerabilities related to some of the things we've discussed today. And then timing of exposure, et cetera. So the earlier you use a drug, the more your brain hasn't finished developing, the more vulnerable it is. And so we know the average onset for mental illness, the average onset for substance use that's severe, and most traumas that greatly impact the body are all happening at that same time. And that kind of childhood or that substance use and mental illness mostly is hitting between late adolescence and early adulthood. So all of this is happening all at once, and your brain isn't even finished developing until age 25. And most people have already turned to substance use or have developed a mental health disorder by that point, before their brain has continually finished developing. So I'm going to go through some kind of visualizations of things that I know are a little hard to read on these tiny screens that you're probably looking at, but this is just kind of different ways to think about trauma. And then we'll look later about some positives with recovery, resilience, et cetera. And so I really think that describing to someone that, hey, it seems like you probably are always on edge, you're kind of listening and aware, you may be easily startled, it's affecting your ability to sleep and feel safe at night. It also kind of random thoughts could come through, and then you're just going to avoid seeing things that you know are going to make you worse. That's kind of an easy, quick way to kind of describe how trauma might affect someone. And a lot of times when I do that, they're like, how did you know that? How did you know that's exactly how I am? Because unfortunately, it's a very classic kind of constellation of symptoms that happens. So I just talked about this a little ahead of time, but the biological vulnerabilities with substance use. And so it's these two things: mental illness and age of encountering the drug. And then again, in substance use, mental illness, trauma, it's all the same parts of the brain that are involved. So the amygdala with our emotions, the prefrontal cortex with decision making. The prefrontal cortex in adolescence is very impulsive. I don't think anyone would be too surprised if you happen to have teenagers around, or you remember when you were a teenager. They make real dumb decisions, and they don't even really realize that maybe wasn't a great idea. But that's part of being a human, and part of development is you have to be somewhat impulsive to find out what happens when I do that thing. The hope is you're impulsive, you see the consequence, you don't do it again, but that doesn't happen in that natural progression for everybody. Mental illness, drug use, substance use are all going to be risk factors to kind of give in to that impulsivity. And then people with mental illness are more likely to be impulsive because their prefrontal cortex isn't developed or appropriately managing things like it should. And then the hippocampus, the memory formation that we talked about before, that's affected by trauma, is also affected by these as well. And so all of these areas of the brain reconnect back to the nucleus accumbens, which I abbreviated and didn't spell out here, but NAC is the nucleus accumbens. And that's part of the brain that's specifically related to motivation. And dopamine is the primary neurotransmitter there. So dopamine is hitting that nucleus accumbens and then telling the brain what behaviors to continue to do. And that's where, if those behaviors are related to continue to use a substance or related to continue to avoid certain people and places, whatever it may be, it's kind of driving all of that through these very fundamental connections between the different parts of the brain. And I know that's a lot of information on one slide, and we could talk about it a lot more, but it is complex, but the overlap between mental illness, substance use, and trauma is very clear. So children are going to be shaped by their caregivers, and there's those experiences, and that's where that intergenerational trauma can progress. We talked about how if they don't have that loving connection, there's kind of either an emptiness or fear or some sort of negative emotion. Drugs, if exposed, become kind of the source of comfort. Drugs provide dopamine. Dopamine provides reward. Dopamine remotivates to do that same behavior again. And so this is where you could fall into this emptiness that's being filled with a drug, because it gives dopamine more than any other connection to anything else. And so drugs become the primary kind of relationship for someone rather than a sense of community or connection with other people. So I'm not going to go into the adverse childhood experiences too much, because I have a feeling hopefully many people on this talk have seen this and understand it. But the adverse childhood experiences is a scale that is extremely well researched. At this point, probably almost 40 years of research that really reinforces that these particular events are directly related to lifelong medical and psychological mental health disorders, and are risk factors for developing things. And so the scale is emotional neglect, abuse, and then just household dysfunction. So this is just kind of a visual that kind of shows them, but I have the actual questions here as well. So I won't read through them, but they're in here if you want to look at them later. But there is physical sexual abuse, and then this one is still written as like a mother father kind of situation, which is not always the home environment for everyone. But it's just the idea that, is there one adult in the household who abused or neglected or had some sort of trauma to the other person? And then also related to, is there history with adults in the household with alcohol, substance use, being in prison, or mental illness, suicide, et cetera, because those are all risk factors related to this individual then developing some other issues later in life. Okay. And then I bring up primary care. I don't actually know where many of you work, but primary care is the, hopefully, primary place people are receiving medical care. That's the hope, is you have a relationship with your primary care physician or nurse practitioner or your physician assistant, and that person becomes the place of care. If we don't recognize trauma in that primary place of care, we're going to miss the opportunity to really impact and help people. And also, people aren't going to respond to typical medical intervention for their health issues if they've had trauma, because they may need a different way of getting that support moving forward. And so this is just kind of some numbers to show that this is very prevalent in the primary care population. And these patients are everywhere. They are people in our lives in all capacity. And so there's just a lot of very significant traumas that have happened. And these are kind of those PTSD-ish kind of traumas that I mentioned before, where there's, a very significant impact with worry about death or whatnot. But there's also in the text here, 59% have had at least one adverse childhood experience, with 9% having 5 or more. 5 or more adverse childhood experiences is a lot. And unfortunately, much, much more common than I think most people realize. So adverse childhood experiences, the goal here is not to make sure time. Okay. We're not trying to blame the caregivers. We're not trying to blame people for these things having happened. It's not just a pass, like, oh, well, that stuff happened and I can't do anything about it now. That's not the goal. The goal is just to understand and appreciate that if you have this risk factor and you have other risk factors and you have certain experiences and you have a lack of attachment and good connection with people, you're going to be very vulnerable to some very impactful issues moving forward. forward in life. And so we really just want to kind of be able to pull all those categories of risk and identify who those people are so that we can better meet their needs in a way that responds to what they have experienced and not re-traumatize or re-trigger them unintentionally because of their experiences. Um, the adverse childhood experiences really didn't originally kind of take into account community stressors. So I just want to kind of bring up the fact that these are very important as well. So the kind of titles at the top are those first 10 ACEs we talked about, and then the adverse community environments below, this poverty, discrimination, community issue, poor housing, violence, and then just lack of opportunity. Those are the things that I think are generationally really continue to affect a lot of people, and also the things that one individual person can't control. And so we have to think as a society ways to improve prevention of some of these things and the impact it has on a set group of people that maybe live in the same area or have similar shared history. So we can't prevent all trauma. Wish we could. Can't happen. But we're going to go into now kind of some strategies or actionable things that you might be able to do, or some evidence-based things that you could potentially implement into your area of care that could really have a really great impact on people. So the hope is that at any point in life, if we can pair a person with a secure, safe, reassuring person, we can maybe undo some of the damage that had occurred before. And the goal is you just have to be good enough at this. So we learn a lot about good enough mothering in psychiatry training, but Winnicott is just one person who kind of got this idea that if there's this safe space by anybody, not just the mother, there's a better chance of healthy, good childhood development. I won't go into time in versus time out too much today, but I can't remember if I have a slide later on this or not, but this is the idea that if you just isolate and separate a kid who's misbehaving and just kind of say, like, you need to go away because you did a bad thing, and you never revisit it, they're not going to learn how to regulate that emotion. And so really helping an anxious child by being present in a way, modeling that response is much, much more helpful. So circle of security is an evidence-based treatment related to trauma. I've seen this mostly in new moms. So maybe they're pregnant and going to have their baby, or they have young children. But the hope is that if you implement this as like a group therapy situation, the moms would actually come while they're pregnant, start learning curriculum. And then once they have their baby, they bring the baby. And so the therapist actually gets to witness the active kind of connection between a mom and a newborn and really model and help them see. And then this next one is it's just kind of thinking about it from a teen perspective. So teens still need mothered or parented in such a way. And so that secure base, that holding environment there is listed at the top. And so if they feel safe and secure, they're going to go out and explore, and they're going to it's kind of like looking over your shoulder to see what happens. So I think a great way to think about this is if you have a, 9, 10, 11-month-old who's learning how to walk, they're going to be pulling up and kind of cruising and trying to balance. If they get pushed down because their caregiver doesn't want them to walk, and like, you're in my way and I'm just going to kind of knock you off the coffee table and get out of my way, if that keeps happening, that kid's not going to keep trying to explore. They're not going to be wanting to learn how to do a new skill, because the only reinforcement they're getting is stop doing that, stay out of my way. Versus the kid who pulls up and is, looks around the room for acknowledgement, like, hey, I'm standing up. If they see bright smiling faces, hear cheering, hear happiness, and they see kind of a really positive response, that baby is going to learn, oh, I should do that again. Everybody seems to like that. That makes me feel good. And they will develop that skill and kind of progress. And so I think that's just a very easy way to kind of understand what could happen. And I think it also is like that one instance, if that's the only thing that happens, that's not enough, right? It's going to be repetitive kind of behaviors like that from your primary caregiver that really interfere with normal, happy, hopefully general movement in a good developmental direction. Okay, so this, I guess I do talk about time in, which is great. Okay, so this is the idea that kids have bad behavior. So behavior is a choice. You get to choose how you behave. You get to choose what you do, right? And so a long time, I think we thought discipline the behavior will stop. People aren't very motivated by being told they screwed up and they did something bad. They are motivated by being rewarded or acknowledged when they do something good. And so the behavior for a child is they're doing something to get a need met and express it. And they generally don't either know what the need is or they don't have a healthy way to express it or both. And so the only way they know, a newborn cries. It cries if it needs absolutely anything. It cries if it's hungry. It cries if it's tired. It cries if it's cold. It cries if it's hot. You have no idea, right? You have to learn and adapt and figure out what does this baby need. Same thing happens. It's just that cry turns into a different behavior as kids age. But if you think about it as a behavior is an unmet need and it's a cry for help, then you're going to be a lot more likely to be able to understand that someone's not choosing to do this behavior. They're asking for help and they're waiting for someone to hear them and to see them and to help them. Substance use is very similar. They continue to make a choice to use, but eventually it's not a choice. They're ending up using because they are physically dependent on the drug, or the withdrawal and physical symptoms related to it are so significant that they can't stop. And then they also generally don't have a way to deal with the negative emotion or connection with the drug. And so without assistance and help and someone hearing their cry for help and their need, they're not going to succeed. And so I really like to kind of reinforce that recovery in any regard is related to connection. We're essentially trying to reconnect and give that healthy attachment in some capacity so that somebody can really improve and develop moving forward. So very briefly on this time in concept, but this is the idea that you should do a time out if you're, and this is not just for parent and child, this is for anybody, right? You're in a conflict, you're with someone else or many other people, and you separate yourself from the stressor long enough for you to calm. And then if you're calm and come back and the other person hopefully has calmed some, that you can then take control and kind of emulate and show how to appropriately regulate an emotion. So in a parent-child relationship, because I think this is the easiest, there's different ways and you want to do different things based on the developmental age of a child and what they can do and understand. And so if the parent, for instance, describes, hey, I had you go to your room and I stayed away because I was sad that you keep doing this and it really upset me and made me somewhat angry. I knew that me being angry at you wasn't going to help you. So I decided to send you to your room, and I'm back now because I want to understand and try to help figure out why did you do that and how do you feel about it? And then maybe we can come up with a better way to deal with that if it happens again. But if you never process the emotion, never label it, never kind of tell the kid anything, it's really hard for them to know what they did wrong. And if a kid is repeatedly given the same punishment for a variety of different behaviors, they also have no idea what they should do and what was wrong because there's no consistency or there's too much punishment and not enough reward or acknowledgement of good behavior. And so this is the idea that separate till you're calm, go back, process, stay with the child until they've progressed and calmed. And hopefully that development and connection that you have will grow and improve over time. And then the child will be able to have their needs met without disruptive behavior moving forward. All right. So in a relationship, if you cannot relate, then there generally is this kind of inability to be empathic. You don't have empathy. If you don't have empathy, you can't connect and relate to someone. If you have an inability to regulate your emotions because you don't understand, never learned, or are too triggered, you're going to fall into kind of a almost like no empathy because you can't control your own emotion, much less appreciate, understand someone else's emotion. So very difficult to be in a relationship if you either don't have the ability to be empathic or you don't know how to regulate your emotions. And if that continues, and someone is in that vulnerable state and really doesn't understand how to make someone want to be with them or be their friend or be present with them, they may turn to drugs. Drugs are a reliable friend. You know exactly what you're going to get. You know exactly how it's going to make you feel. And that predictability becomes comfortable. It's obviously dangerous and scary and really impactful for people. But eventually, because they've not been getting their needs met, they find a way to get their needs met. And so the drug use can become a replacement for relationships, but then it also is an obstacle once they decide they want a relationship. Now they're stuck in this pattern of behavior and they maybe can't get out without additional help. And so without connection and relationship with people, and the replacement for that feeling the drug's getting, really hard for people to end up in good recovery. So in traditional addiction treatment, which is still occurring, but thankfully not kind of the norm, there was a lot of expectation on you follow the rules or you get kicked out. And so you had to be compliant. It was very confrontational. You do this, you get this medicine, you can't use your drug anymore. If you use your drug, you're out. That's very similar to timeouts and to punishments and all sorts of things we do to kids that don't work. And so thankfully, and it's some acknowledgement of the shame that can come with that. And then traditional addiction treatment is very, it's not individualized. There's no collaboration. It's just everybody gets the same treatment. Everybody has the same expectations. It's also very cognitively based. It really relies on the prefrontal cortex and really expects people to be able to understand, you make this action, you have this consequence. That's not realistic. They're not in a space where that part of their brain is working. They're relying on that amygdala, that emotional processing, or that kind of automatic response in the primitive brain. They don't have the ability to think, plan, and execute the way that's needed in the way that traditional addiction treatment has required previously. So now I'm going to just kind of some concepts or other ways of what else you could do instead of traditional addiction treatment. And there's millions of these systems of care options out there. So I just pulled some kind of a few concepts, primarily from SAMHSA or the NIH, some of those kind of organizations and kind of what they've pushed through. But this is one concept with the 4 Rs. And so realizing the impact the trauma is having, the person, the individual themselves realizing, but also whoever is having that connection relationship with that person, recognizing the impact the trauma has in terms of symptoms, and then integrate that into how we have policies, procedures, et cetera, and then try not to re-traumatize. So it's kind of just a very vague kind of overarching idea as to what trauma-informed care could be. And so this SAMHSA graph I kind of like because it has that safety, so that kind of safe haven or kind of attachment kind of place where you have a place where you feel safe as the base, that secure base, and then you kind of work through all these things. It shows linearly, it's not necessarily going to be linear, but it's just kind of the idea that you're building up more and more supports and ways to think about things. And I like this one because that peer support piece is pulled in. And I think having people with lived experience in any capacity is going to be a great option for connection for people earlier in the process. And then a collaboration and choice. Those next two, I think, are really, really key, because if somebody has a choice in how they're going to approach their recovery, they're going to be a lot more likely to engage and want to do it. Excuse me. And then this is just some kind of words and concepts, but some of these things might jump out at somebody as something you maybe didn't think about in terms of what someone with trauma might benefit from. I want to just highlight the predictability. So we talked about chronic, unpredictable, toxic stress, or kind of you don't know what to expect. And so if you can create a predictable environment where somebody knows, I come in, we do this, we kind of progress. I know we're going to wrap up our treatment with this, and then I get to express how it went for me, and then I get to go home. You're a lot more likely to kind of come in prepared for something like that. If there's surprises and nobody really knows what's going to happen, or you kind of wing it all the time, that can be really tough for somebody trying to process and find support for their trauma. And then a bunch of other concepts here, some of which we talked about. So then we want to progress to some resolution of our symptoms, right? So we want to create some sort of holding environment. In my case, in an outpatient mental health clinic, it may be that my relationship as the psychiatrist with a patient becomes the initial holding environment. We may be able to create a safe space and a connection different than what they've been able to experience. And that may be that initial foundation. A treatment provider system can be this safe holding environment for people. And then we hopefully create connection outside of a treatment facility where they have support, et cetera. But wherever that holding environment can be, it just needs to be a place where they feel safe. You also need to be in a psychological state that's different than when you were in the trauma. in order to be able to heal. And so if you're constantly triggered or constantly in a space that is reminding you through nightmares, intrusive thoughts, whatever it may be, you're going to struggle to heal. I think adult children living in the home in a very dysfunctional relationship with their parents is a great example. It's really hard to get somebody who's an adult living in their parents' home or the primary caregiver's home to recover if there's a history of connection and trauma and difficulty there. So, and then just some other kind of ideas here, but the mindfulness piece is not the just kind of vague term of social media mindfulness, but kind of this idea that you have to feel things in order to understand your needs and how to get them met. And so if we just keep avoiding, we're not going to progress there. And then I think that the belonging sense of community, that purpose is really key, because a lot of people end up in recovery. They're not using a drug anymore. They're, I have all this free time and I don't have very good connections or relationships. What do I do? And so if they can find a sense of purpose through work, through volunteering, through mutual support groups, whatever it may be, it can make a really big impact. And then the hope is that through treatment like EMDR or some sort of trauma processing therapies, whatever it may be, that they may be able to integrate memories and then not have them have so much power over them moving forward. All right, some more kind of sometimes cliche ways for building resilience, but just some things to kind of reflect on. But again, the support network has to be created and then utilized. We've got some pillars of resilience here, just kind of similar concepts, but other ways to think. I like to pull out the yellow bar, the flexible thinking. If you can't plan and execute and stop being impulsive, you also can't be flexible. So this is a much further along in the process kind of idea, but people have to be willing to have, I can't control everything and I have to be willing to adjust depending on what happens. Some more interventions or kind of ideas just for review. And then in conclusion, I want to make sure I leave some time for questions. Early childhood, where the child has no control, is a very important time frame. And so in a prevention effort, if we can create environments either through community or through schooling or through medical treatments, whatever it may be, if we can create an environment where kids can learn early, we might be able to be preventing some of these chronic impacts of traumas, chronic illnesses that occur, because that childhood period is such a vulnerable time. Any sort of rapport, safety building, any sort of treatment retention is really important. My goal when I meet a new patient is to get them to come back the next time. So if I can't meet my agenda or I can't get through everything, that's okay. My goal is I want you to trust me as best we can, having just met. And, an hour after you meet me, I want you to feel like you got something out of that enough that you come back. After that, we can start working through everything else, right? So you've got to build that safe space as quickly as you possibly can. Just like we want to treat mental illness and addiction together, we want to treat trauma and addiction together. So we really have to think about how to incorporate and connect all these. And then thinking about recovery and being in recovery as a connection. That connection can mean different things to different people, but without connection, you're going to have isolation and avoidance and fear and all those negative emotions. And so we really need to connect in some capacity. And then just a reminder if we rely on our traditional treatments and we're really based on CBT and like cognitive process, people aren't in a space to do that early in recovery, and they're going to fail because their brain is not equipped to be able to think in that way. So really thinking outside the box and really creating a treatment in the early stage of recovery that is much more simple and based more on that kind of emotional processing and emotion regulation pieces. And then I have some references in here, which I won't leave up, some resources, but I will leave it on the thank you slide for a minute, and then I'll pull over the evaluation slide here as well. So I'll turn it back over to coordinating some questions.
Thank you, Dr. Zars. I learned a ton. We do have a couple of questions coming in. For someone who asked, yes, these slides will be available after the presentation. They'll be in a thank you email that you'll get following. One question is, I know they say wherever they started in their addiction is they say the age where they are when they're not using. So how long does this take for them to catch up in their age? Do you understand what that question's asking?
Yeah.
Okay.
Yeah. And I think trauma is kind of similar too. So I didn't get into that a lot today just because we had a lot of things to talk about, but internal family systems, if you're not familiar, is a really good way to conceptualize some of this too. So evidence-based therapy option. But the idea is that if your brain developmentally is kind of hijacked by substance use, maybe at 14, 20, whatever it is, you had hopefully some reasonably normal development up until that point. And then the dopamine and kind of reward, the motivation all gets hijacked by the drug. And so now normal expected things don't provide reward or connection. And so in a way, yes, many people end up being kind of that adolescent or early adult because they never learned how to manage other things because the drug took over. I explain this to patients as like, hey, the last time that you didn't have something powerful in your brain kind of dictating your next move and kind of making you seek out more drug was when you were, a teenager. When you were a teenager, you were also not independent. You didn't have to make all your own decisions. You hopefully had someone who was taking care of a lot of your needs. And now as an adult, you're in charge of you. You have to make sure you've got money. You have to make sure you have a place to live. You have a lot of responsibilities. We need to get you from the last time you felt safe and secure and somewhat connected to now and learn how to deal with those responsibilities. And so that's kind of how I try to conceptualize that age difference in terms of development that can happen. But it has a lot to do with dopamine and motivation, that reward system.
Thank you. Thank you. Looks like I've got some questions coming into my email too. One is, so you mentioned that there is a connection between age of starting to use a substance, and likelihood of addiction. And I know people who suffer from a mental illness may be more likely to become addicted to substances. If someone starts using substances early, does that also raise their possibility of getting a mental illness? Is that like a two-way street?
Yeah, it definitely can be. Since the drug could connect to parts of the brain and create some vulnerability, that sent if enough miswiring or kind of if it's pruned in such a way where it reinforces certain pathways that are maladaptive and more linked to mental health symptoms, they may develop an illness. I think psychosis and developing a true psychotic illness like schizophrenia is a great example, which the drug, and it's many drugs, but primarily cannabis, followed by cocaine and stimulants like methamphetamine, they're the most likely to kind of create this psychotic space in the brain. And if there's enough exposure and enough connection there, that you can develop a permanent psychotic illness that was triggered by substance use. And so there is unfortunately a very high likelihood there. So I think that's a very easy one to kind of understand what happens there.
Okay, thank you. Another question we have, what about the uptick in young use of meds for ADHD? Is this linked to substance use disorder?
So there is a big connection between ADD and substance use disorders, but it really has to do with the impulsivity. So ADD is an impulse control disorder, substance use is an impulse control disorder. If you don't treat ADD, that person is going to continue to develop their prefrontal cortex in a way that's maladaptive and impulse based. If you do treat the ADD, you can actually prevent substance use. So it is important to treat ADD in the appropriate individuals in the appropriate way, but it can prevent ongoing mental health symptom development or substance use development, because they're going to be able to kind of use the cognitive processing the way they're supposed to. So there is a higher prevalence in treatment for ADD in younger people now, but we also have progressed and learned a lot more about symptoms. We also have a lot more treatment options than we did before. And so it's really hard to correlate what decisions we're making in treatment now compared to the 1990s, because we've studied and researched and understood, and then we also have more effective treatments than we did. So I really don't love backtracking to past ways of doing things or past epidemiology, because we weren't diagnosing the ways we needed to previously. And so if you expand medical knowledge, you're going to expand diagnosis.
That makes sense. Thank you. Another question I'm getting in my email. So, since there is a lack of mental health resources available in our state and elsewhere, if someone goes into a group 12-step program, is that enough to help them with their substance use disorder, or would you say that's not enough normally?
It can be for some people. So if some people can develop that connection and safety quickly in that setting, they may do great. People who have more fear or trauma with connection with people and are kind of hesitant to be open and get their needs met and ask for what they need, they're going to struggle in that environment. And so it has to be individualized. There has to be options. If you have severe trauma and you have substance use and you may or may not have mental illness, you may need more services. But mutual self-help, 12-step, any of that kind of stuff is a viable option for a decent chunk of people because they need that connection. They need like-minded people who have shared experience, and they need a space to go when they're not doing well so that they can have that support. That can be enough for a lot of people, but many people with other risk factors and vulnerabilities are going to need more.
Okay. Yeah, that makes total sense. I will ask if you'll just skip ahead one
Oh
slide.
yeah, thank you. I was
Yeah,
going to
the
do that and I forgot.
evaluation link. And I'll wait a couple of minutes just to make sure any more questions come in. Thank you all for joining us today. Thank you, Dr. Zars, for an awesome presentation. I learned so much from that. Um, and yeah, you'll be sent, everyone who joined us today, if you registered, you'll be sent a thank you email with link to the slides, link to the evaluation, and then also some instructions for if you would like to claim nursing contact hours for this webinar. We'll leave it up for a couple of minutes, and thank you all for being here. I'm just going to check to make sure no more questions have come in. Awesome. Thank you all so much for joining us today. Thank you, Dr. Zars. We really, really appreciate you taking the time to be here.
Absolutely. Thanks, everyone.